the hydatid disease today. So hydatid disease, hydatidosis, and echinococcosis, all of them mean the same. It is a zoonotic disease. So hydatid disease, hydatidosis, or echinococcosis is a zoonotic disease. It is caused by the species Echinococcosis. Right? So it is basically a tapeworm, cystoda. Now this Echinococcosis has following species which are infected to humans. One is Echinococcosis granulosus, Echinococcosis multilocularis, Echinococcosis vogeli, and Echinococcosis oligarthris, of which the most common species causing hydatid in humans is a Echinococcus granulosus. Right? So this Echinococcus granulosus causes hydatid disease, and this is expansive. Right? It spreads by expanding, or not by invading. Echinococcus multilocularis causes what is called as alveolar echinococcosis. Right? So this is granulosis is cystic echinococcosis, where a cyst is formed. This causes alveolar echinococcosis. See now, alveolar echinococcosis doesn't mean that it infects the lungs. It more commonly infects the lungs, but the most common organ that is infected by either granulosis, multilocularis, ovale, or oligarthrus is liver only. What alveolar echinococcosis means is that this usually causes a multiloculated cyst. So there are multiple locules, multiple vesicles inside the cyst, which resemble the alveolus of the lung. So that is why it is called as alveolar echinococcosis. Right? So the reason that it is called alveolar echinococcosis is not that it primarily infects the lung. Even multilocularis primarily infects the liver only. But it is called alveolar because it has the multiloculated cyst, and these multiloculated cysts give the appearance of an alveolus. And this spreads by invasion, right? So because it spreads by invasion, this causes a fast destruction of the liver parenchyma. Right? So the liver parenchyma is invaded and it is destructed. So because it is invading and destructing, this resembles a malignant disease. That is why it is called as a malignant hydatid disease. Right? So two misnomers and pseudonomers. One, it is not called alveolar because it infects the lung. It is called alveolar because of the appearance that it has. Second, it is called malignant hydatid disease not because it is malignant, but because of the nature of its spread. It invades rather than expanding, and it causes the destruction of the liver, so which is akin to that of a malignancy. That is why it is called as malignant hydatid. Now, Vogeli and oligarthrus, they cause what is called as neotropical echinococcosis. Right? So these also are cystic lesions. Vogeli is largely polycystic, produces a polycystic disease, but oligarthrus produces a unicystic disease. Right. So these are the species, but of which the most common is cystic echinococcosis, which is caused by Echinococcus granulosus. So when you look at this parasite, now this parasite is basically a cystoda. Now, cystoda is nothing but a tapeworm. Now this parasite has got a larval stage and it has got an adult stage. Right. So this larval stage is what is the hydatid cyst. So hydatid cyst is the larval stage, and the adult stage is the tapeworm. Now this adult tapeworm, it has got a scolex. Scolex is the head of this tapeworm. So this is the adult tapeworm which has got the scolex, and this is the neck, right? So this part which is in front, this is called as hook that helps it to attach to the intestine of a definitive host. And then there are two suckers. So these are the two suckers. This is hook, and then there is a neck of this. After this, this has got three segments. So one is a immature segment, and then there is a mature segment, and at last there is a gravid segment. Right. So this is the rostrum. This is the sucker. This is the neck. So this part is called as a scolex. And then this has got an immature segment, this has got a mature segment, and then there is a gravid segment. These segments are also called as proglottids, right? So immature proglottid, mature proglottid, and the gravid proglottid. Now, this gravid proglottid, this is a hermaphrodite, like the male and female reproductive organs are present in the same organism. So that is why it does not need to depend upon another of its species for the reproduction, right? So the mature segment has got the male reproductive organs, and the uterus is present in this gravid segment. So this is the uterus in the gravid segment, and this uterus has got this gravid segment has got this genital pores, and through these genital pores, thousands of ova are released. Right, so this causes release of this ova or eggs. Right, so it has got a larval stage, which is a hydatid cyst, and it has got an adult form, which is a tape form, and this adult form is seen in the small intestine of a definitive host. Right, and a larval stage is seen in the organs of the intermediate host. Right. So all these, most of these parasites to complete their life cycle, they need a host, and these hosts are classified as a definitive host and an intermediate host. Right. So a definitive host is where the sexually active form is present, right, which is a mature form. For example, a larva cannot produce eggs, right? A larva has to get converted into an adult, and only this adult, which has got a proglottid, this can produce eggs, right? So the sexually active form is a adult tape form, which is seen only in the definitive host. Or in other words, those hosts which can provide an environment where the larva can get converted into an adult are called as definitive hosts, right? So they are definitive hosts where the sexually active form is present and they will shut down their ova. In case of a hydatid echinococcosis, the definitive hosts are usually canids, right? So they are dogs or foxes, right? So this Echinococcus granulosus, the definitive host for this is usually dog. That is why it is also called as dog tapeworm. But for Echinococcus multilocularis, the definitive host is usually a fox. That is why it is also called as fox tapeworm, right? And then intermediate hosts. Intermediate hosts are required for the completion of the life cycle of this tapeworm. These intermediate hosts provide an environment where the egg can hatch into a larva, which is a sexually immature form, but it cannot provide an environment that is sufficient for the larva to grow into an adult form. Correct. That means that in an intermediate host, a larva can further differentiate into a larva only. It cannot get developed into an adult form. So that is why it is an intermediate host. So the intermediate host for this Echinococcus granulosus is usually sheep, or it could be cattle. So cattle or sheep is the intermediate host, are the intermediate host for the Echinococcus granulosus. Now the humans here are accidental hosts or aberrant hosts, right? So accidental host or aberrant host is in the natural life cycle of this cystoda, humans are not required. So even if all the humans are extinct from the planet, still the dogs, foxes, sheep, and cattle can manage the survival of this. They can ensure the survival of this tapeworm. Humans are not actually needed for the completion of this cycle. And yet, if they are infected with the eggs of this cystoda, that will result in a disease in these patients, right? So, in summary, definitive host is one which can provide environment and host the sexually active form of the cystoda. Intermediate host is one which cannot provide the environment for the conversion of a sexually immature form into sexually mature form. So that's why it hosts only the sexually immature forms. Accidental intermediate hosts are those which are not required for the completion of the life cycle of this cystoda, but yet if they are infected, that will result in the disease. Right? Is this clear? Hello.
Yes, sir.
Now, what happens to the life cycle of this? So we'll start with the definitive host. So the definitive host in this case is a dog, right? So dog is a definitive host means it contains the adult tapeworm. Now this adult tapeworm is present in the intestine of this dog, right? So the intestine of the dog has got villi. So this villi is attached the adult tapeworm, right? Which is has three segments and it is less than 1 centimeter. It is hardly 2 to 7 mm. Now this starts shedding eggs. So thousands of eggs are shed into the feces. Now these eggs which are shed into the feces, the dog feces, they are highly infective and they are highly resistant to the extremes of the temperature. They can even survive the coldest of the cold temperatures. Now, when a intermediate host, say a human or a sheep or a cattle, comes in contact with this, so directly it can be a sheep grazing cattle, sorry, grass grazing sheep or cattle, or this species gets contaminated with the water and that water is taken up by the humans. So, any intermediate host which ingests these eggs, so egg ingestion by intermediate host. Now, these eggs pass through the esophagus, they'll enter into the stomach, nothing happens, they'll enter into the duodenum. In the duodenum, these eggs will hatch into what is called as oncospheres. Okay. So, it is a spherical structure which has got six hooklets. Right? So, this is an oncosphere. So, this is a spherical structure which has got six hooklets. With the help of these hooklets, this oncosphere will attach to the wall of the intestine and it will penetrate the wall of the intestine and it will enter into the blood. Right? So, it gains access into the blood. But the oncosphere of the multilocularis can also gain access into the lymphatics. Right? So, this will enter into the blood and in the blood, it will disseminate to various organs. The most commonly, it involves liver. Right? And the second most common organ that is involved is lung, but it can also involve bone, it can involve muscle, it can involve brain, it can involve kidney, it can involve spleen. So hydatidosis can occur in any of these organs. So but the most common is liver. So once this oncosphere enters into the liver, in the liver, this oncosphere gets converted into a hydatid cyst. Right? Now this hydatid cyst is the larval form. Now this hydatid cyst, if it was in a definitive host, say it could have got converted into adult tape form because it will enter into the bloodstream and it comes into the intestine. In the intestine, the hydatid cyst actually contains what is called as protoscoliosis. We'll see it further. So these protoscoliosis are the future heads of the future scoliosis of the adult tapeworm. So in the intestine, this scoliosis will evacuate from the capsules that is contained inside and they grow into the adult tapeworm. But that environment is not provided by the intermediate host. In the intermediate host, a hydatid cyst can only differentiate into further hydatid cysts. So these are present in various organs. Now, when this dog or fox comes and ingests the organs that contain the organs of these animals, like if it comes and eats the liver of the sheep or muscles of the sheep which contain these hydatid seeds. So these hydatid seeds will enter into the dog's intestine and in the dog's intestine they'll get converted into adult tapeworm. So they will evacuate the cyst and they will get converted into adult tapeworm on eating the organs of the sheep or cattle that contain the hydatid cyst. So this completes the life cycle. Now the same thing happens in the humans. Up to here, the hydatid cyst formation happens in the humans, but it is extremely rare for a dog or a fox to eat the human organs, right? So they usually eat the carcasses of other herbivore animals. So it is naturally extremely rare for them to eat the carcass of a human organ. So that is why the humans are considered to be end point of its life cycle. So they are the end hosts of the life cycle. So once it forms a hydatid cyst in the human, it stops at the human. But if it forms a hydatid cyst in any other herbivore animal, it continues and contributes to the further life cycle. Right. This is clear. Hello.
Yes, sir.
No. Hydatid cysts, again, going by the same principle, most of them, 75% of them are seen in the right hemiliver. Now, because this is a parasite, the human body, the liver tissue develops a capsule, a fibrous capsule around this cyst. So this is called as a pericyst. Right? So the outermost layer of the cyst, which is pericyst, this is not derived from the worm, but it is actually derived from the host tissue. And this pericyst is a fibrous layer that is formed around the hydatid cyst. Inside this fibrous layer, there is the actual layer of the hydatid cyst, which is called as ectocyst. So the cyst wall is made up of two layers, an outer ectocyst and an inner endocyst. Right? Now this ectocyst is again acellular. It does not contain any cells. It contains hyaline. So because it contains hyaline, it is called as a gelatin membrane, or it is also called as laminated membrane. So the laminated membrane refers to the ectocyst. Now this laminated membrane is very loosely attached to the pericyst and it can be easily peeled off from the pericyst. Sometimes spontaneously it gets peeled off from the pericyst and lies into the hydatid cyst fluid, giving rise to the water lily sign. So that is what is a water lily sign. Because this ectocyst is loosely attached to the pericyst and can be easily peeled off, that gives rise to the ectocyst. That gives rise to the water lily sign. And inside of that is present the endocyst. Now, this endocyst is actually an alive layer, right? So, both pericyst and ectocyst are acellular layers. Endocyst is an alive layer, and this endocyst is called as germinal membrane. Right? Now, it is this endocyst which produces ectocyst on the outside, and on the inside, this ectocyst produces brood capsules. Right? So, these are all the brood capsules that are produced by this endocyst, and inside these brood capsules it produces the protoscoliosis, right? So these protoscoliosis are future scoliasis, future worms, worm heads. And this also produces the fluid inside. So this fluid inside is called as the hydatid fluid, right? So the endocyst is the germinal layer, and this germinal layer produces ectocyst on the outside, and on the inside of the cyst it produces brood capsules that contain the protoscoliosis and the hydatid fluid. Now, sometimes as the time goes on, these brood capsules will disintegrate. And when these brood capsules disintegrate, they will release these protoscoliosis into the hydatid fluid. Right? So these degenerated brood capsules and the protoscoliosis and the hydatid fluid together are referred to as hydatid sand. So once these protoscoliosis are produced, they will produce further cysts, and these cysts are called as daughter cysts. Right? These daughter cysts will again, some of them will disintegrate, they release the protoscoliosis, and they will in turn produce some more cysts which are called as granddaughter cysts. Right? So that's how the cysts keep on replicating. Right? So this is what happens to a hydatid cyst. Now, this hydatid cyst, as I said, it keeps on expanding by production of more cysts on the inside and production of ectocysts on the outside, and it increases by expansion. As it keeps on increasing by expansion, there are two things that can happen. One is the cyst will progress, it causes hepatomegaly, and it keeps on increasing in size. Second is sometimes spontaneously the cyst will die. Right? So the cyst degenerates and the cyst dies off, or the cyst can rupture into various parts, right? So this hydatid cyst can spread by expansion, causing progressive hepatomegaly, or the cyst can degenerate and calcify. See, all if you get an ultrasound and you see that there's a calcified cyst, it doesn't mean that the cyst has dead, right? So whenever you get a calcified cyst, it is better to follow up with serial ultrasounds. Even on serial ultrasounds, the size of the cyst remains same. It means that the cyst is dead. But on serial ultrasounds, the cyst size keeps on increasing. The cyst is still alive, right? So calcification is one of the indication that the cyst may be dead, but it doesn't mean that always the cyst is dead if it is calcified, or it can rupture. So when the cyst ruptures, most commonly it ruptures into a biliary tree. So when it ruptures into a biliary tree, it forms what is called as cystobiliary fistula, right? So there's a communication between the cyst and the biliary tract. This cystobiliary fistula can be a small cystobiliary fistula, or it could be a large cystobiliary fistula. So if it is less than 5 mm, it is called as a small cystobiliary fistula. If it is more than or equal to 5 mm, it is called as a large cystobiliary fistula. Now, this small cystobiliary fistula, most of the times they will close spontaneously, but the large cystobiliary fistulas, they need some techniques to close them. They need closure or some techniques to let them close, right? So these large cystobiliary fistulas, when they happen, so when the fistula communication is more than 5 mm, it is likely that the daughter cyst, the hydatid fluid, or the brood capsules, they will enter into the biliary tree. So when they enter into the biliary tree, they cause recurrent cholangitis. So if a patient with hydatid cyst has got recurrent cholangitis, then it is a suspicion that there might be cystobiliary fistula. This is one. Or they can dilate CBD. So there can be dilated CBD. And those fistulas, which are those cysts which are more than 10 centimeter in size, they are likely to have a cystobiliary communication. So these are the three things that has to be sought preoperatively to see if there is any cystobiliary communication or not. So first is the patient developing recurrent cholangitis because of the hydatid sand entering into the biliary tree. Second is the cyst CBD is dilated, and third, any cyst with more than 10 centimeter diameter is likely to have a cystobiliary communication. So if this suspicion is present, it is better to get a MRCP or ERCP, right? So ERCP is gold standard. MRCP is the investigation of choice to rule out the cystobiliary communications. So this is the most common area of rupture, that is into the biliary tree. Now, this rupture can also happen in the pleural cavity. It can happen into the pericardial cavity, especially if it is a cyst is in the left hemiliver, or it can happen into the tracheobronchial tree or into the peritoneal cavity. So, rupture anywhere in the pleural, peritoneal, and pericardial cavities will initiate fatal anaphylactic reactions. And if the cyst ruptures into the tracheobronchial tree, and then the patient will have expectoration. So he coughs this hydatid sand. So we'll have this expectoration with white flaky material. So this is the course of the hydatid disease. Now, what are the clinical features? So because there is a cyst in the liver and it is increasing in size, so the most common symptom of the patient would be pain abdomen. Right? There could be some amount of vomiting and there could be some amount of dyspepsia. And if the cyst got infected, it can lead to pyogenic abscess and that can result in fever. If the cyst is too large, it can compress onto the CBD and lead to jaundice. And if the cyst ruptures, then the patient will have anaphylactic reactions. The most common sign would be a hepatomegaly. Right? So there is hepatomegaly, and then there is the classical sign that is called as hydatid 3. Right? So over the mass that you palpate, you place three fingers and you percuss onto the middle finger. The thrill is felt onto the other two fingers, which is the classic hydatid thrill. Right. And depending upon the place of the rupture or site of the rupture, there will be clinical features of that. Right. And when you investigate this patient, so it is a radiological investigation and a biochemical investigation, which is serology. Lot of tests are available for serology, but most of them are having less specificity and less sensitivity. So that is why we mainly rely on radiological diagnosis. Right. So in radiological diagnosis, the first line of investigation would be an ultrasound. Ultrasound will very well tell the hydatid cyst, and the classification of the hydatid cyst is also based on ultrasound or CT features. You can get a CT abdomen done. If you are suspecting a cystobiliary communication, then ERCP or MRCP can be done. So on ultrasound, initially the classification system was a Garby's classification system. Right? So Garby classification system was type 1, type 2, type 3, 4 and 5. So type 1 Garby's, see the cyst contains clear fluid. Because the cyst has clear fluid, it should be anechoic, right? The sound does not pass through it. So that is anechoic cyst will be there, which is a pure cyst, which has got only the hydatid fluid. In second, there is a cyst, and this cyst has got a fine split membrane, right? As I told you, the ectocyst can sometimes get detached from the pericyst and it can lie in the hydatid sac. The third is the cyst has got septations because as the daughter cysts are released, when the brood capsule disintegrates and these scoliosis enter into the hydatid cyst and the daughter cysts are further formed, so that will produce some septae. And the fourth is mixed echogenicity is there. So there is hypoechoic also and some hyperechogenicity will also be there. So hypoechoic and hyperechoic, both of them. And fifth is it is calcified. So it is partially calcified or completely calcified, but it is a calcified cyst. So this is Harvey's classification. So there's a pure cyst and a cyst with split membrane, then a cyst with septae, then mixed cyst echogenicity, which is hypoechoic and hyperechoic. Then there's a calcified cyst. But now what we use is a WHO classification. WHO classification is first is a cystic lesion, then cystic echinococcosis type 1, cystic echinococcosis 2, 3A, 3B, 4, 5. Now this 4 and 5 are similar to Garby, right? The 4 is type 4 in Garby, 5 is type 5 in Garby, right? So the 4 will be there is a hypoechoic and there is hyperechoic, which is mixed echogenicity. This gives the appearance of bag of wool, right? And fifth is a calcified cyst, which could be a complete calcification or it could be a partial calcification. Right? Now, cystic lesion is one way which is purely anechoic. Now, cystic lesion, cystic echinococcosis 1 is there is an anechoic cyst which is totally black, but there is one membrane that is floating. So, it is a fine internal echo. So there is a fine internal echo, and as you change the position of the patient, this membrane also changes its position. So it is like a falling snowflake. It is called as falling snowflake sign, or some also call it as a double line sign. In 2, as the cyst degenerates, the brood capsules and daughter cysts will enter, and that is why, though the cyst is anechoic, there are septae that are formed. Right? So because the cyst has got these septae, it looks like a multivesiculated cyst. And because it is multivesiculated, it can look like a cartwheel, it can look like a rosette, or it can look like a honeycomb. So it can have a cartwheel sign, rosette sign, or honeycomb sign, just because there are lot of daughter cysts and granddaughter cysts inside. So this is basically a daughter cyst that will be. And 3A is where there is a cyst and the ectocyst gets completely detached. So there is a detachment of the ectocyst that gives rise to a water lily sign. Right? So there is a detached ectocyst which gives rise to a water lily sign. And 3B is the cyst with solid matrix. So this is WHO classification. Now, why this is important is the CIS 1 and 2, these are considered to be active CIS, right? The 4 and 5, these are inactive cysts, right? 3 is a transitional cyst. Right? So 1 and 2 are active cyst, 3 is transitional cyst, and 4 and 5 are inactive cysts, right? So the 4 in WHO classification is same as that of a GARB4, 5 is same as that of a GARB5, right? So the 3A is actually the cyst with a detached membrane, which is nothing but a water lily sign, which is seen both on ultrasound and also in CT. This actually corresponds to GARB2, right? Because in GARB2, I told that there's a cyst with detached membrane, split membrane, right? And then the 3B is GARB3, the 2 is GARB3, right? Because of fine septate. So this is the only thing that you need to remember. 2 and 3B are GARB3, but 3A is actually GARB2. So now how to treat it? Now the treatment of choice for any hydatid cyst of the liver is always surgery, right? But there are some alternative therapies, which are the medical therapy and the percutaneous therapy. So when it comes to medical therapy, this medical therapy is indicated in number one, for before any intervention, you need to give a medical therapy. And after intervention, for some amount of time, you need to give medical therapy. So medical therapy is a part of whether you do a percutaneous therapy or a surgical therapy. Second is if there's a disseminated hydatidosis, where hydatid is present in multiple organs and you cannot treat all of these organs, then the only way is medical therapy. And third is if there is multiple recurrences, right? After percutaneous therapy or surgery, if there are multiple recurrences. And fourth, if the patient is a poor surgical candidate, right? So in elderly patients. This hydatid disease is usually seen in around the age group of 45 years and equal sex distribution of male and females. Right? So now, in medical therapy, the drug of choice is albendazole. Earlier, mebendazole was used, but it is not used anymore. So albendazole with praziquantel. Right? So now, this albendazole with praziquantel, this has to be given 10 days before any intervention and has to be continued for 3 to 6 months after intervention, right? So it is anywhere between 10 days before intervention and 3 to 6 months after intervention it is continued. Albendazole is given in a dose of 10 mg per kg body weight and praziquantel is given in a dose of 60 mg per kg body weight. Now albendazole is given as a pulse therapy. So 1 month of albendazole is given. Then there is a gap of 2 weeks. Then again 1 month of albendazole is given. And then a gap of 2 weeks. And so on. So in this period, any 2 weeks of praziquantel would suffice. So 2 weeks of praziquantel, 60 mg per kg body weight, and 3 to 6 months of albendazole with 2 weeks of drug-free period at a dose of 10 mg per kg body weight. Right? Mebendazole was initially used around 600 mg QID, but that is not used nowadays. Nowadays, it is albendazole with praziquantel. Right. But this is contraindicated in case of pregnancy. Now, the next technique would be a percutaneous aspiration. So, this is a minimally invasive technique which goes by the acronym PAY. Right. So, if there is a cyst, now this cyst is punctured under ultrasound guidance or CT guidance in the non-dependent part through the thickest part of the pericyst. so as to avoid spillage later. Right? So it is punctured, and which is punctured, then it is aspirated. 50% of the fluid is aspirated, and then a scolicidal agent is injected. Right? So there are various scolicidal agents available, of which the best agent would be a hypotonic saline. Betadine can also be used. Ethanol is used. Cetrimide was used. Hydrogen peroxide has also been tried, and sodium hypochlorite. Right? So hypotonic saline is around 15 to 20% of hypotonic saline is used. Betadine 5 to 10%, 5% is also fine. Ethanol in the range of 75 to 90%. Right? So hypertonic saline can cause hypernatremia. So is with sodium hypochlorite. This can also cause hypernatremia. Cetrimide, anywhere you hear cetrimide, it is acidosis. Ethanol can cause sclerosing. It is a sclerosing basically. So it can cause sclerosing cholangitis. Right? So whenever there is a suspicion of cystobiliary communication, only the hypertonic saline has to be used, right? Because all other agents have some potential to cause sclerosing cholangitis, so it is better to use a hypertonic saline. So once you aspirate it, you insert this scolicidal agent, and after you inject this scolicidal agent, you wait for at least 20 minutes, and then you re-aspirate it, right? So sometimes they also inject a sclerosing agent and then re-aspirate the sclerosing agent. This is pair. So if the cyst cavity is more than 6 centimeter, you can put a drain into it and leave the drain. So that is called as pair D, percutaneous aspiration, injection, re-aspiration, and drainage. So where a indwelling catheter is placed. So this is paid. But the most important is surgery. So the treatment of choice is surgery. Surgery ranges from a non-radical approaches to radical approaches. So the radical approaches are cystopericystectomy and partial hepatectomy. Right? So if there is a cyst here, those cysts which are usually peripherally located and are easily accessible. So these cysts are removed along with the pericyst. Right? Along with the pericyst, the cyst in toto is removed. This is called as cystopericystectomy, where the entire cyst is removed along with the pericyst, or sometimes if the cyst is in the left lobe of the liver, along with the part of the liver that is removed, that is called as partial hepatectomy. But these are radical procedures. Now there are certain non-radical procedures, so which can be done via an open approach or it can be done via the laparoscopic approach. So now whether it is open or laparoscopic approach, the principles remain same, right? So once you expose the liver and sufficiently mobilize the liver, and then there is a pericyst here, you do a similar procedure to that of a peri. So before that, if at all the cyst ruptures and it spreads into the abdomen, there is a high chances of anaphylaxis. So the anesthetist is ready with adrenaline and steroids, and we as surgeons should put colored mops all around. So the entire abdomen is packed with the colored mops. Colored mops are because the cyst is white in color, so it is easily visible on a colored mop. So the entire abdomen is packed with colored mops, and then you aspirate the cyst. And after you aspirate the cyst, you inject the scolicidal agent, and once you inject the scolicidal agent, you wait for 20 minutes. So after you wait for 20 minutes, now you de-roof the cyst wall. So if this is the cyst wall, the roof of the cyst wall is removed. So that is called as de-roofing. So as you remove the roof of the cyst wall, you will encounter all the daughter cysts inside, and you will encounter that there is a lot of fluid. So all this fluid, daughter cysts, they are all evacuated and they are all removed. So as the daughter cysts and the fluid is removed, so what remains is if this is pericyst, so then there is a ectocyst and an endocyst, right? So ectocyst, endocyst, all other things are removed. Now, as I told you, the ectocyst is easily detachable from the pericyst, and the ectocyst is also removed. Now, as you remove this ectocyst, what remains is the pericyst and the cyst cavity. Right? So till here it is same. Right? So you open the abdomen, either by open method or laparoscopy. You expose the hydatid cyst part of the liver. Then you pack the abdomen. Once you pack the abdomen, you aspirate, inject a spolicidal agent, wait for 20 minutes, and then you de-roof the cyst wall. So as the cyst wall is de-roofed, you will encounter the hydatid fluid and the hydatid sand, daughter cysts and all. You evacuate all of them, and then you remove the ectocyst with endocyst, which is easily detachable from the pericyst, and then again you inject a spolicidal agent onto this, and then you aspirate it. Now the cyst cavity is there. Now there are ways to deal with the cyst cavity. So once there is a cyst cavity, the next thing you need to do is you need to see whether this cyst cavity is communicating or not, right? So communication of cyst cavity. So this could be a communicating cystobiliary fistula is present, or there could be communicating cystobiliary fistula absent, right? So if it the communicating cystobiliary fistula is absent, then your only concern is to close the cavity, right? So or you need to deal with the cavity. So how to deal with the cavity? Number one, if there's a liver and this is the cavity, you can just put a drain into this cavity and leave it. So that is one is drainage of the cavity. Right. Second is this is the liver and then there is this cavity. So the walls of this pericyst are sutured to the edges of the surrounding liver. So this is called as marsupialization, where the healing is fast, right? So you can marsupialize it. Or third, if this is the cyst cavity, the liver, usually it is done for the lung hydatid, right? So in case of a lung hydatid, you take bites to the base and the wall in a spiral fashion, right? So what happens when you take bites? So if this is the cavity and you keep on taking bites from the base of the cavity to the walls of the cavity slowly keeps on occluding, and then you can suture it off, right? So it is basically done for lung hydatid, where in a spiral manner from the base till the top, sutures are taken so as to slowly occlude the cavity, and whatever is remaining, it could be stapled or a suture can be put on top of that, right? So this closing of the cavity is called as capitonage. And number four, so if this is the cyst wall, what you can do is you can take bite onto the cyst wall and a bite onto the base, cyst wall and to the base. So slowly as you do this, the cyst wall will be inverted like this, right? So this is by inverting the cyst wall. This is called as introflexion, right? Capitonage, introflexion. Fifth is if there is a liver, sorry, if there this is the liver and there is a cyst cavity, you can take the pedicle of an omentum and you can pack this cavity with the pedicle omentum. Right? So you take the pedicle omentum and pack this cavity with the pedicle omentum, and then you suture this omentum. So this is called as omentoplasty. So these are all the ways by which you can deal with the hydatid cyst cavity, right? So you can just put a drain, or you can do a marsupialization or a capitonage, which is usually done for lung hydatid, or you can infold the edges of the cavity, which is called introflexion, or you can take the pedicle omentum and place it into the cavity and secure it to the edges, which is called as omentoplasty, right? So this, if there is no cystobiliary fistula. Now, if there is a cystobiliary fistula, how to confirm this cystobiliary fistula? One is preoperatively. As I told you, preoperatively, if the cyst size is more than 10 centimeter, if the cyst has got, uh, there is a cyst with dilated CBD, or if the patient has got recurrent pyogenic cholangitis. So if these are there, you do an MRCP and you rule out a cystobiliary fistula. Right. In case of intraoperatively, you can get an intraoperative cholangiogram, or simply if the cyst is bile stained, right? So if there are no bile stained cysts and this is the cyst cavity, you can take a white mop and you place this white mop into the cyst cavity, and then you gently squeeze the gallbladder. So as the gallbladder is squeezed, if this gets stained with bile, it means that there's a cystobiliary communication. So if there is a cystobiliary communication, there are ways to deal with it. Number one, so this is the cyst which is communicating with the biliary tree, small radicals of the biliary tree, which will eventually lead to the formation of the right and left hepatic ducts. So in such cases, if it is small, it is away from the biliary confluence, you can evacuate the cyst and you can directly suture this fistula, right? So this is direct suture. Using a slowly absorbable or delayed absorbable suture is used and it is sutured off, right? So, but this is not ideal if the cyst was very deep or it is near the confluence of the biliary ducts. Second is bipolar drainage. So, in bipolar drainage, what happens is, so this is a cystobiliary communication. All these will eventually form the right and left hepatic ducts, which receives the gallbladder duct, cystic duct, and then it forms a CVD. Now here, because it is a cystobiliary communication, some hydatid sand will be there in the cyst also. So you do a choledochotomy and you place a catheter, you pass a catheter through here, you give the thorough wash and you drain all the hydatid sand. Then you place a drain here into the cyst cavity, which will drain the cyst cavity, and then you close this choledochotomy over a T tube. So you place a T tube and you close this choledochotomy. So whatever the bile is, the fistula is between the cyst and the biliary tree, right? The cyst is drained outwards and the bile is also drained downwards and outwards. So it is a bipolar drainage. So there's a principle in surgery that if you keep the distal ends open, all the lateral cavities will close by themselves. Even in small ureteric injuries also, if you place a stent, the distal end is open. So because of that, all the lateral openings will also close. So similarly, you drain the cyst, you drain the bile, the fistula will close by itself, right? And then there is one more procedure where the cyst is anatomical, where the fistula is anatomically disconnected. That is called as Parodome procedure. Right? So what is done in Parodome procedure is, this is the cystic cavity in the liver, and then there is this cystobiliary fistula, right, which will eventually, all this will form the CVD. Now here again same. So choledochostomy is made and a drain is inserted here, a catheter is inserted, wash is given, all the hydrated sand is drained. Now a catheter is passed through here and this comes all the way through the biliary tract and it will enter into this fistula and it passes through the normal hepatic parenchyma and it comes into the from the anterabdominal wall into the outside into the atmosphere, right? And the fistula is lodged here. So now a fistula, or sorry, a catheter is lodged in the fistula. So there is a catheter through the biliary tree, through the choledochotomy. It is present in the cystobiliary fistula, traverses a part of the normal hepatic parenchyma, and then is brought outside through the anterior abdominal wall. So this is one. Two is, this is a multiperforated drain. One more multiperforated drain is placed in the cyst cavity, right, to drain the cyst. Right? And third, whatever this was opened, this is closed over a T tube, right? So now there's a biliary drainage away from the fistula. And whatever the cyst is there, now this cyst fluid will be drained outside into the through the intra-abdominal wall. Now, this catheter, what is placed, this actually passes from the cyst into the normal hepatic parenchyma and outside. So, this eventually will form a tract here. So, now the tract is formed between the biliary tree and the normal hepatic parenchyma, bypassing the cyst. So, cyst is now totally disconnected from the biliary tract. So, this is the anatomical disconnection of the cyst from the biliary tract by placing three drains. One is T tube, one is a multi-perforated drain in the cyst cavity, and another is a multi-perforated drain